and we're going to be discussing some respiratory cases, and I'm going to talk you through some questions today. So question 1. The medical registrar at the Grand Round shows a chest X-ray of a male patient who has an industrial lung disease. The chest X-ray shows small rounded opacities, mostly in the upper lobes, and no calcification is visible. There is no hilar lymphadenopathy. The question is, of the known industrial lung diseases, which one of the following is the most likely given these chest X-ray findings? There are 5 options, and I'm going to give you a few moments to think about them and choose the correct answer. The correct answer here is coal dust. This patient's chest X-ray findings are consistent with a diagnosis of coal workers' pneumoconiosis. And those are 2 X-rays depicting this condition. Coal workers' pneumoconiosis typically causes multiple small round opacities which are tiny, usually 1 to 10 millimeters in diameter, mostly in the upper lobes, and that's what you see on the X-ray on the left-hand side. However, with the passage of time, these opacities can come together and merge, giving rise to a more severe and serious chest X-ray appearance on the right-hand side. In asbestos lung disease, you get lower zone fibrosis, which you can see on this chest X-ray in the form of some reticulonodular shadowing. However, another clue which may be present but not always are pleural plaques, which are of the same density as the ribs and can be seen on this chest X-ray. They look calcified. In silicosis, typically one gets multiple small nodules scattered throughout the lungs, mainly in the upper zones as illustrated in the top left-hand corner by a circle. We also get hilar enlargement and calcification of the hilar lymph nodes. And if you look at this patient's right hilum, it is calcified in a very peculiar eggshell typed shape. And this is supposed to be quite diagnostic of silicosis, although not always present. In patients with chronic beryllium disease, classically one gets progressive upper zone linear interstitial fibrosis, which is more evident in the right upper zone in this picture. However, beryllium lung disease can manifest with many different X-ray appearances. The classic one is not always to be found. Question 2. A 20-year-old man has recently started work in the bakery section of his local supermarket. He complains of increasing shortness of breath, cough, and wheeze during the course of the working week. These symptoms resolve somewhat at weekends and improve markedly during a week's holiday in Spain. So the question is, which one of the following initial actions is the most appropriate in this case? Look at the 5 options, spend some time thinking about them, and then we shall discuss the correct answer. The correct answer here is B, 2 hourly peak flow recordings during the week, comparing work to rest periods. And why is this correct? Well, it's very important here to establish a link between this patient's clinical features and his work, because what you're suspecting here is occupational asthma, and this really is the only test that will accomplish this. So a few words about occupational asthma and its diagnosis. It should be considered in all asthmatics. The commonest causes are diisocyanate dyes, often used in the chemical industry, particularly in the pesticide industry. Baker's asthma is another very common one, as is latex-induced asthma, present in healthcare workers due to exposure to latex gloves. The way we diagnose occupational asthma initially is by doing serial measurements of their peak expiratory flow rate. These measurements need to be done every 2 hours from waking to sleeping for 4 weeks. And what you're looking for is a dip in the peak flow rate associated with exposure to the work environment. I'm just going to now go back to the different options and talk through them, explaining why the others are incorrect. So A, trial of salbutamol is incorrect. It might relieve the patient's symptoms. However, it doesn't actually help you diagnose occupational asthma, as it doesn't show any link between the causative factor and the symptoms. Chest X-ray, again, you'd expect to be relatively normal in asthmatic and doesn't lead you any closer to the diagnosis. Bronchial provocation testing is done sometimes, and you can actually try and stimulate symptoms using the specific allergen. However, it's not a very widely available test. It should be done in a controlled environment, and actually I wouldn't say that it's a first-line test because it's so difficult to do. As far as patch testing is concerned, well, all that will demonstrate is that the patient is sensitized to flour in this case, but that doesn't actually mean that the patient has occupational asthma due to flour, because a lot of people without asthma or eczema can be sensitized to various allergens, and that doesn't mean that they have a disease because of it. Question 3. So it's a repeat of the previous scenario. You've got a 20-year-old man who recently started work in the bakery section of his local supermarket. Then he went on to complain of increasing shortness of breath, cough, and wheeze during the course of the working week. And he reported that these symptoms resolved partially at weekends and more markedly during a week's holiday in Spain. We discussed this patient in the last question, and we advised peak flow monitoring. And this was performed, and it confirmed evidence of occupational asthma. So we found a link between him being at work and his peak flows dipping. The question for you is, which one of the following represents the most appropriate management plan? You have 5 options. Take some time to think about them, and we'll discuss the answers. So if you chose option C, which is remove the worker from exposure with the employer's help, you were correct. This is because relocation away from the exposure should occur as soon as you make a diagnosis of occupational asthma. We do this because the prognosis for workers with this disease is worse for those who remain exposed for more than 1 year after the development of symptoms, compared with those removed earlier. So the longer you're exposed, the worse your lung function is going to become. It's worthwhile remembering that some patients may be entitled to disablement benefits, so this should be discussed with them. I'm just going to go back to the options and discuss them with you. So, salbutamol inhaler, PRN to use at work. Well, yes, if the patient gets breathless and wheezy at work, then if he uses his salbutamol inhaler, he might feel a bit better, but it would not stop disease progression. And again, neither would inhaled steroids. Just asking the worker to leave the supermarket would not be fair and would actually be against employment law. Regular inhaled steroids and long-acting beta-2 agonist therapy, again, might make the patient feel somewhat better, but would not halt disease progression. So really, every effort should be made to relocate the worker within the same organization in an area where he might not be exposed to the allergen. Question 4. A 52-year-old immigrant from the Balkans presents for review. Over the past few months, he has suffered a number of fevers and night sweats and has lost a significant amount of weight. The chest X-ray reveals a small to moderately sized right-sided pleural effusion. He has a positive tuberculin skin test. A pleural tap reveals a lymphocytosis, although staining for acid and alkali-fast bacilli is negative, and protein count is 41 grams per liter. The question is, which one of the following diagnoses fits best with this clinical picture. Have a look at the options and we shall discuss the answers later. The correct answer is B, tuberculous pleural effusion. In a patient from Eastern Europe who has a positive skin test for tuberculosis, constitutional symptoms, and an exudative pleural effusion, TB is indeed the most likely possibility. It's worthwhile remembering that a simple AAFB smear test is only positive in 5 to 10% of pleural fluid samples of tuberculous effusions. Culture may be positive up to 25% of the time, but this can take up to 6 weeks. If the patient is producing sputum, that might be helpful. The definitive test here is a pleural biopsy. Ideally, you'd like to do this thoracoscopically to maximize your yield. And if you perform a thoracoscopy and obtain a pleural biopsy that way, the yield is in excess of 90%. If a CT scan reveals focal abnormalities of the pleura, you can actually take a sample under CT or ultrasound guidance. However, in areas with a high TB prevalence and poor availability of image-guided or thoracoscopic biopsy, often a blind pleural biopsy is done. The sample should be sent in 2 separate pots for histology and microbiology. In pleural effusions due to TB, the smear is only positive in a minority of cases, so a negative smear test should not be taken as evidence of ruling out TB. The culture is positive in up to a quarter of patients, but can take up to 6 weeks, and the patient may need treating in the interim. Sputum may be helpful. However, a lot of patients with tuberculous effusions may not be producing sputum at the same time. The definitive test which one should go for, really, as soon as the diagnosis is suspected, is pleural biopsy. Preferably, this should be done thoracoscopically so that you get a direct view of the pleura and take samples from the appropriate area. If there are focal areas of abnormality of the pleura, the biopsy can be done under CT or ultrasound guidance. The sample should be split in 2 and sent separately for histology and microbiology. Just a couple of practice points here. Lymphocytic effusions are very common, and the presence of one should not be taken to mean TB automatically. These effusions can occur in malignancy and also in cardiac failure. And indeed, any long-standing effusion can become populated by lymphocytes. Now, this patient had a positive tuberculin skin test. This is not diagnosis of the disease tuberculosis. All it means is that the patient has had TB infection at some point in the past and has been sensitized. So the reason that this patient is likely to have TB is not because of the skin test per se, but because of the overall clinical picture with the symptoms in particular. You notice that our patient had a pleural fluid protein content of 41 grams per litre. That's quite high and would be indicative of an exudate. But to define whether a patient has an exudate for sure, you need to apply Light's criteria. And just a reminder of these criteria: if one of the following is fulfilled, the patient has an exudate. So, number 1, the pleural fluid protein content is more than half of the serum protein content. Number 2, the ratio of the pleural fluid LDH to the serum LDH is more than 0.6. Or the pleural fluid LDH is more than 2/3 of that lab's normal upper limit for serum LDH. Question 5. The patient is the same as in the previous question, a 52-year-old immigrant from the Balkans who over the past few months has had fever and night sweats and has had some weight loss as well. His chest X-ray shows a small to moderate right-sided pleural effusion. He has a positive tuberculin skin test. His pleural fluid is lymphocytic. He has an AAFB stain, which is negative, but the fluid turns out to be an exudate. He then proceeds to have a pleural biopsy done under thoracoscopy, and this reveals appearances consistent with tuberculosis. So, the question is, which one of the following diagnoses fits best with the treatment of this condition? You have some time to look at those, and we shall discuss the correct answer later. The correct answer is E. Anti-tuberculous chemotherapy should be continued for 6 months. I'll talk through the other options one by one. Unfortunately, in pleural tuberculosis, oral corticosteroids do not really make much of a difference, so they aren't recommended routinely. During the course of treatment, pleural fluid volumes may initially increase before finally diminishing. Also, pleural thickening and calcification are quite common in pleural tuberculosis. As far as anti-tuberculous chemotherapy is concerned, the minimum treatment duration is 6 months. There is no 3-month treatment regimen. However, in patients with latent tuberculosis as opposed to tuberculosis disease, chemoprophylaxis with isoniazid and rifampicin may be given for 3 months, but that is different from anti-tuberculous chemotherapy. So, just to talk you through standard TB treatment, your standard regimen is for 6 months. The initial 2-month induction period is with 4 drugs: isoniazid, rifampicin, ethambutol, and pyrazinamide. This is followed by a continuation phase with just 2 drugs, isoniazid and rifampicin. It's worthwhile pointing out that even if you have bone tuberculosis or miliary pulmonary TB, the duration remains 6 months. Corticosteroids in tuberculosis are typically recommended in patients with TB meningitis, where they have been shown to reduce mortality. Also, patients with tuberculous meningitis have treatment for a longer duration, typically 1 year. Patients with pericardial tuberculosis, again, should be given corticosteroids. There is a suggestion that steroids reduce pericardial constriction and mortality. Question 6. A 44-year-old man presents with a rash on his legs and feeling generally unwell, with malaise, weight loss, and fevers. He's also recently noticed some loss of sensation over the top of his right foot, and the foot has been dragging when he walks. He was diagnosed with asthma by his GP many years ago and was using a salbutamol inhaler as required. He's also had a constant watery nasal discharge but no epistaxis. He was also a non-smoker. When seen by you, he had a low-grade pyrexia and scattered wheeze in his chest. Heart sounds were normal. His abdomen was soft and non-tender with no masses. He had a purpuric rash on his lower limbs and several tender subcutaneous nodules on his forearms. He had a right foot drop, but no other neurological abnormalities. So, here are his investigations. I'm not going to read them all out to you, but just point out the abnormal ones. His hemoglobin is on the low side, 10.6 grams per deciliter, so he is a bit anemic. White cells are normal. If you look at his differential cell count, you'll notice that his eosinophil count is quite elevated. The normal range for eosinophils being 0.04 to 0.4 times 10 to the power of 9 per liter. His ESR is quite high. You'll notice that his ANA is negative. His P anchor is positive. Urine dipstick is normal. His chest X-ray shows some abnormalities, so he's got some patchiness at the hilar regions, along with a small pleural effusion. So, the question here is, which one of the following is the most likely diagnosis? I shall give you some time to think about that. The correct answer here is Churg-Strauss syndrome. The answer is not SLE because, if you remember, this patient had a negative ANA, which would be very odd in SLE. Also, you'd expect the anchor to be negative in SLE. Apart from this, the clinical picture doesn't really fit with a patient with SLE. You'd expect a rash with or without some joint involvement, typically. Polyarthritis nodosa presents with very vague, non-specific symptoms. Again, you would expect the anchor test to be positive. As far as Goodpasture syndrome and Wegener's granulomatosis are concerned, it would be very unusual to have normal renal function and a negative urine dipstick, although that can happen. Also, in Goodpasture syndrome, you'd expect a negative anchor and a positive anti-GBM antibody. In Wegener's granulomatosis, the anchor that goes up is your C anchor rather than the P anchor. The chest X-ray appearances in these conditions are also different. In Goodpasture's, you tend to get fluffy shadowing at the bases, whereas in Wegener's, you tend to get nodular shadowing in the upper zones. You would also expect some upper airway involvement, so involvement of the voice box or the nose in Wegener's. I'm just going to do a quick run through Churg-Strauss syndrome, which is often underdiagnosed because it's not very well recognized by many people. It's a small vessel vasculitis associated with asthma and eosinophilia. As our patient did, there is a prodrome, typically of several years, of allergic rhinitis and asthma that has been thought to be difficult to control. Often there is an association with mononeuritis multiplex, and if you remember, our patient did have some peripheral nerve involvement. As opposed to other vasculitides, renal involvement is not usual, especially initially. Chest X-ray appearances are quite varied, and there isn't really any typical X-ray picture. The P anchor is positive in up to 75% of cases. The treatment is multi-pronged and typically would consist of steroids and steroid-sparing immunosuppressant medication. Of course, to treat the asthma component of Churg-Strauss, you would continue your standard asthma management. There is one important caveat though, and that is that leukotriene antagonists such as montelukast should be avoided, because there is a suggestion that there might be a link between the use of these drugs and the actual development of Churg-Strauss syndrome, although it hasn't been completely validated. So, with that, we come to the end of Lecture 3, and also the series of lectures on respiratory medicine for MRCP Part 2. It's been a pleasure instructing you, and good luck with your exams, and I hope to see you again in another